We have been operating the Emergency Pressures Initiative since 1994, which was initially piloted through winter pressures funding to support the timely discharge of older people from hospital by providing small-scale adaptations such as grab rails, stair rails, etc., as well as minor repair problems. However, this initiative was very much based on a responsive, reactive service, and so the contact with the patient was limited. Whilst we followed up queries expressed in our client survey, I had real concerns that we were just scratching the surface in terms of helping these patients with their long-term housing needs.
I'd been a community caseworker for 15 years, but working under the pressure of an acute hospital is completely different. Our service had helped patients get out of hospital in the past, but we were always waiting for a referral, and as much as we promoted ourselves, communication was difficult. Being part of the NHS culture and a discharge planning team, but with a non-medical expertise, brings real benefits. I have access to older patients, their families and the carers very early during ward rounds and presence in the hospital, and so we can resolve issues quickly and get access to the home without delay. We've been able to solve so many problems that would have held up safe discharge, some of which have emerged during conversations on the ward rather than being required within a referral. Speed is a massive issue for the NHS resources, and I hear so much positive morale about our ability to improve patient flow. We currently have a new A&E emergency pressures pilot scheme in the Princess of Wales, and one example sums it all up really. I recently took a query from A&E, and within a couple of minutes and a short walk, I was involved in resolving an issue that helped resolve a bottleneck and improved the patient experience.
It's made a difference. I can get out to the shops, I can go and catch the bus, you know, I can get out of the house, I got my freedom, I can get fresh air, I can go up the garden, you know, I can just do what normally I always used to do. I bet doing it from a wheelchair. I can't understand being home without a way of getting out of the house, because if ever there was a fire or anything like that or an emergency, I couldn't have got out of here. Yes, I've had my operation and somebody's waiting for perhaps an operation like I had, and they're waiting for a bed, but I would not come home without my house, getting out of this house safely.
I manage Pendre Day Unit, which is in the throes of undergoing a little bit of change to become a medical day unit. But the bread and butter of the unit, in amongst other services, is that we run a falls assessment service. So we get referrals from multiple sources from within the hospital and within primary care from GPs for patients who are vulnerable, frail and falling. And they come in and they have a holistic assessment. With every will in the world, you can get like a picture of what's happening at home, but it's not until you actually set foot in somebody's property that you can you start assessing from the beginning, really, don't you? We've developed an excellent rapport, I think, with the small team, because I don't think there's a lot of them, but for a small team, their response is really, really quick.
Prior to Care and Repair stepping into the fold, were waiting on services like Care and Repair to go out to put telecare into situ before they could go home. So of course we didn't have the reactive service that we got now. Now it's a completely different kettle of fish. I can do discharges within 24-48 hours is what we work on, and that's because telecare can be also in place within 24-48 hours if I need them to. We've cut that, slashed that in half, if not more. Benefits is another big thing. How am I going to pay for this care? They won't accept it sometimes because they think of the price before anything. Yeah. They don't need to be here, not when there's flu, not when there's pneumonia, not when there's all the other germs going around. they've got something, they'll have an infection, they're back on antibiotics, and that's the rolling thing. They get one thing and it holds them up. They'll get another thing. When they're medically fit, home. Yes. That's where you go to get better.
One of the things that we're so impressed with is the speed of which we can get adaptations completed within the home. And that allows us to facilitate somebody's discharge promptly and get them back into their own home, into their own environment, and facilitates patients' flow throughout the hospital. It could take up to 7 to 10 days for a referral to be started, completed, actioned, and for us to know that it has been completed and in place. Now it can be done within 24 or 48 hours if needs be. What we try and do is let care and repair know that discharge is anticipated for such and such a day, so that we're working together really. So if it isn't a priority, then obviously it can wait a couple of days, then fine. We do try and give as much notice as possible, but obviously when we work in places like the emergency department, in acute medical wards, we need equipment and adaptations to be in as soon as possible. So we really need that feedback, and we can actually get that now. We can get that service in, say, within 24, 48 hours if needs be. Without that, there'd be a massive backlog at the front door of patients waiting to be seen in emergency departments and waiting in the emergency department, waiting for a hospital bed on the ward. So without that there to facilitate the discharge, there would be a bottleneck at the front door, which obviously is longer waits in hospital, and that's not good for patient care or patient experience. When you come into hospital, you're vulnerable anyway, and by having a named face and being able to have that conversation with ourselves as occupational therapists, but also with the people that are going to be going out and doing some of the adaptations, that gives those people the confidence and that control to say, yes, that's what I want, no, that's not what I want. But it gives them the confidence that they've got a legitimate person to go into their home and to complete the works that's needed. And I think you can't underestimate the value of that. And I must be honest, it was always a friendly voice on the end of the phone. But there is nothing like having a conversation with somebody on a day-to-day bit and having that face-to-face contact.
I have to say that none of this would have been possible without the strong partnership arrangements and the forward thinking of the health board, local authority teams, NHS staff, and of course last but not least my fabulous staff that have worked so hard to make it all happen.